Welcome everyone to the recorded webinar series on LED-based photoacoustic imaging. My name is Mithun and I'm a Research and Business Development Manager at Cyberdyne. In this series, several key opinion leaders in the field of photoacoustics will talk about LED-based photoacoustic imaging and its preclinical and clinical applications. Today's exciting presentation will be a clinician's perspective on the potential of LED-based photoacoustics in the guidance of minimally invasive surgical procedures and will be delivered by Dr. Simeon West, who is a consultant anaesthetist at University College Hospital, London. His research primarily focuses on improving visualization of nerves and medical devices for interventional pain. As part of the Wellcome EPSRC Center for Interventional and Surgical Sciences Research Group, he has published more than 45 articles in the field. He sits on the board of the UK division of the European Society for Regional Anesthesia and lectures internationally on the use of ultrasound for guidance in regional anesthesia. In this webinar, he will talk about the potential of LED-based photoacoustics in guidance of minimally invasive peripheral vascular access procedures. With that, I will turn it over to Dr. Simeon West.
Welcome. Thank you for viewing this presentation. My name is Dr. Simeon West. I'm a consultant anaesthetist at University College Hospital, London, with an interest in ultrasound and regional anaesthesia. And I'm presenting the guidance of minimally invasive peripheral vascular access procedures using LED-based photoacoustic imaging. Vascular access is required in most medical specialties where venous access is needed, as well as more advanced applications. For instance, arterial access in anaesthesia, where it is used for blood pressure monitoring and sampling, in cardiology for percutaneous coronary interventions, and in interventional radiology. Traditional landmark-based techniques are largely successful, where knowledge of surface anatomy along with digital palpation is used to find vessels. But the use of point-of-care ultrasound, or POCUS, has exploded in recent years due to the ease of use, cost, and efficacy. Ultrasound overcomes many of the drawbacks of traditional landmark techniques, such as an inability to identify aberrant anatomy and impalpable pulsation due to, for example, partial occlusion, low flow states, or obesity. Difficult access is now commonly facilitated by ultrasound guidance, and many practitioners use it as a standard of care. Indeed, advice from the National Institute of Clinical Excellence in the UK is to always use ultrasound for central venous access procedures. B-mode ultrasound helps with not only the visualization of vessels, but also the interventional devices used to access the vessels and those being inserted into the vessels, allowing the prospect of real-time guidance from start to finish. But it's not without its own limitations. Ultrasound predominantly differentiates tissue types where there are variations in acoustic impedance. Many tissues have a very similar impedance, so may not be easily resolved as different to each other. This is shown here in the image of a femoral artery, where the large artery is easily seen, but the nerve, which is only around half its size, is barely visible in relation to the surrounding tissues. Particular to vessels, arteries and veins are often co-located. Misidentification of arteries for veins can be catastrophic, as injection of certain drugs into an artery can lead to limb ischemia distal to that artery, resulting in pain, loss of function, and even amputation. Techniques to distinguish between arteries and veins include identification of pulsation, the collapsibility of the veins with the ultrasound transducer, and the use of colour Doppler. But none of these is 100% accurate in all situations, for instance, in low flow states. Sound must be reflected by tissue interfaces back to the transducer to generate an image. If the angle of insonation is such that the ultrasound is reflected partially away from the transducer, targets can be missed. Similarly, where medical devices are inserted at steeper angles, reflected sound away from the transducer leads to the reduced likelihood of imaging the device. This is shown in the second image. The addition of photoacoustics has the potential to improve many or even all of these shortcomings. The photoacoustic effect occurs where pulse light is absorbed by certain tissues, and the resultant heating effect produces an ultrasound signal. The wavelength of the light can be tuned to the tissue of interest. Photoacoustic imaging using tunable lasers has generated exciting avenues of research, whilst more recently, much smaller and potentially more practical sources have been developed, like light-emitting diodes, or LED. Hemoglobin is a prominent optical absorber, and so arteries are good targets for photoacoustic imaging. Additionally, metal surfaces such as those of medical needles produce a strong photoacoustic signal. The combination of ultrasound and photoacoustic imaging may provide tissue-specific imaging, coupled with optimised device visualisation. The use of LED sources has the potential to provide medically safe, relatively low cost and small footprint integrated devices. One such system has been produced by Cyberdyne, and we used it to study the effects of LED-based photoacoustics on various aspects of ultrasound-guided vascular access. The transducer of the system is shown here, and you can see how the LED arrays are arranged adjacent to the ultrasound transducer. Firstly, we looked at the capability of improving the visualization of uncoated metallic needles using photoacoustic imaging. A 14-gauge needle was inserted into a chicken breast ex vivo at a number of angles ranging from shallow to steep, and the needle was imaged in plane using both ultrasound and photoacoustic imaging. The signal-to-noise ratio was measured and was found to be consistently higher with PAI, with signal-to-noise ranging from 1.2 to 2.2 times higher at angles ranging from 26 to 51 degrees. Visually, you can see some difficulty in imaging the needle in the ultrasound picture, which deteriorates with increasing angles, whereas the PA overlay dramatically improves the image. It should be noted though, a 14-gauge needle is large bore when considering medical needles, and one would expect to be able to see it quite readily, even at high angles of insertion. In this experiment, photoacoustic imaging provides information complementary to the ultrasound image, while still allowing all of the ultrasound image to be seen. In the next experiment, a phantom was constructed to represent a typical vascular target, using a cylinder with blood mimicking properties embedded in a chicken breast. A 14-gauge needle was inserted into the phantom in plane towards the target structure. Here we found that the vascular target was readily resolved at a clinically useful frame rate in conjunction with the medical device, neither of which are easily seen on the ultrasound image alone. Whilst one can see tissue deformation caused by the needle in the ultrasound image, the ready identification of the entirety of the linear structure of the needle, including most importantly the tip, would give greater confidence to a clinician. This shows that both the target structure to be accessed and the medical device accessing it can be seen at the same time, hence could be very valuable to improving the success rate of vascular access procedures. Next, we moved on to in vivo vascular targets to determine whether these could be seen as readily as the constructed vascular phantom. In the first experiment, we used the digital arteries of the finger. Here, the probe was placed along the finger to image the artery in its longitudinal axis. Real-time ultrasound was used to identify linear pulsatile structures, and photoacoustic imaging was confirmatory that these minimally pulsatile structures were indeed the digital arteries. Additional subsurface signals were also seen, which might have represented venous structures partially collapsed due to the surface pressure of the transducer. Small vessels were chosen as our initial targets of interest due to the expected limitation of optical absorbance in tissue, but next we wanted to assess what sort of in vivo depth could be achieved with this current system. We visualised the brachial artery of a human volunteer. The upper wall of the artery at a depth of around 1.2 centimetres is clearly visualised here. Frame rate achieved was 15.4 Hz, interleaved ultrasound and photoacoustic imaging, which is acceptable for clinical use. This demonstrates that deeper and more clinically relevant targets can also be seen with the system, despite the expected reduced penetrance of externally delivered light. It was interesting, though, that the PAI predominantly enhanced the vessel walls in both experiments. A deeper vessel can be seen in this ultrasound image, but it is not contrasted by the PAI. In our final experiment, we used intermittent occlusion of a blood pressure cuff to model restriction of flow in blood vessels, like might be seen in conditions such as atherosclerosis or acute thrombosis. We hypothesised that photoacoustic imaging could respond rapidly to cessation of blood flow and similarly quickly to recovery. An upper arm blood pressure cuff was placed on the arm of a volunteer. The blood pressure was taken to establish systolic blood pressure. A figure of 200 millimeters of mercury was then determined to be sufficiently higher than the measured systolic to ensure complete cessation of blood flow. The photoacoustic imaging probe was used to image the digital artery of the finger in real time, and the cuff inflated slowly to the chosen pressure. It was then held at this pressure for a short period of time and steadily released to zero. Response to cuff occlusion and reinstatement of blood flow is shown in the video. You can see how the pulsatile flow is initially visible. As the cuff pressure increases, flow reduces, and then when cuff pressure exceeds systolic blood pressure, flow ceases altogether. It's then rapidly reinstated as cuff pressure is released to below systolic and back to zero. This technique demonstrates the capacity for high frequency sampling rates in the photoacoustics, as well as in the ultrasound image. It should be noted that whilst visually blood flow ceases, oxygenated blood should still be present in the vessel, and this is not seen on the photoacoustic image. This may be a function of aggregation of the red blood cells, leading to a change in the absorption coefficient of the oxygenated blood in stasis. If this technique were to provide additional information in low flow states to colour flow Doppler, then this would need to be overcome. Interestingly, Fourier analysis of the amplitude time curve can generate the heart rate. Non-invasive measurement of blood flow could be very useful in assessment of a number of other useful parameters, such as cardiac output, stroke volume, cardiac contractility, left ventricular ejection time, and total peripheral resistance, all of which can be derived from measures of peripheral blood flow. LED photoacoustic imaging has the potential to improve vascular access procedures by enhancing visualizations of vessels, blood flow, and needles. We have shown in these experiments how LED photoacoustic imaging can be integrated with clinical ultrasound to add tissue-specific contrast for arterial structures, as well as enhancing the imaging of metallic needles. Further research is needed to identify whether smaller needles and other non-ferrous medical devices like catheters can be usefully enhanced. Similarly, enhancing contrast for venous structures would be particularly valuable. Tissue-specific imaging has the potential to enhance other procedures, like the identification of nerves by the use of lipid-enhancing wavelengths, the avoidance of small vasculature in nerve blocks, and the identification of optical contrast agents such as indocyanine green. These contrast agents could be useful to enhance the visualization of drugs being injected into vasculature or drugs injected next to nerves, improving safety and efficacy for these procedures. Hurdles to overcome include reducing heat produced by the LEDs and further increasing the depth of imaging. We can envisage a future where photoacoustic imaging using LED sources could be integrated into clinical ultrasound systems to enhance the visualization of structures such as nerves, blood vessels, muscle and bone. Safe identification of these is paramount to safely performing a wide variety of medical procedures, not just vascular access, and photoacoustic imaging is very likely to have a role in tissue-specific imaging complementary to standard B-mode ultrasound. I'd like to thank all of our collaborators from Cyberdyne, King's College London, University College London and University College Hospitals London. Particularly my long-term collaborators Dr. Adrian Desjardins and Dr. Wenfeng Xia. Cyberdyne kindly gave us unlimited access to their device and invaluable help in these experiments. From the university side, this research received funding from sources including the Wellcome Trust and the EPSRC. Thank you.